Hello, and thank you for joining us for another edition of Matters of the Heart, a program brought to you by Haverhill Community Television and Pentucket Medical Cardiology. My name is Dr. Sunny Srivastava. I'm a cardiologist at Pentucket Medical here in Haverhill. I'm joined today by one of my associates, Dr. Seth Bilazarian, and we're going to talk about a topic that I think is very common and something that I think may affect many of our patients. We're going to talk about high blood pressure, but a little bit in more detail, something that we refer to as resistant hypertension. And Dr. Bilazarian will end up defining what that means, but I think it's somewhat intuitive when you use the expression resistant hypertension. We'll talk a little bit about some newer therapies and some exciting things that have come along that we can update the audience on. And so with that, I will pass it over to Dr. Bilazarian and ask him maybe he could just define for us what is resistant hypertension, and we can go from there.
Sure. Well, hypertension, first of all, I want to define that because some people think hypertension means they're tense and they're uptight, and that's not what hypertension is. It's a term that means high blood pressure, basically. So hypertension is high blood pressure, and we've really focused in the last several years on the top number called the systolic blood pressure. And I think generally speaking, we'd say that a blood pressure that's over 140 is high. But for the purposes of what we're talking about today, resistant hypertension, the definition is a person whose blood pressure remains elevated despite being on 3 different drugs at their highest dose. So when a physician prescribes one drug, we recheck them, prescribes a second drug, we recheck them, we prescribe a third drug, the blood pressure remains elevated. That is a person who has resistant hypertension. So that's sort of the shortest answer about what that is.
And how common of a problem is that?
Estimates vary, as you can imagine. It's one of those things that the whole diagnosis of hypertension is difficult to assess because many people don't get their blood pressure checked, don't come in for treatment, don't get screened, don't even get their blood pressures checked in the Walmart or the CVS kiosk screenings. But estimated probably between 5 and 10% of the total blood pressure population of high blood pressure patients. That's probably the estimate. So that's the beginning of what we're dealing with. So a lot of patients. We're talking millions of Americans with many as 30 to 40 million with hypertension, and 10% of that will be 3 or 4 million Americans.
Now, maybe you can address, is it some rare anomaly these people have that causes them to be resistant, or what's causing this?
Well, the whole issue of hypertension, I think our current model of hypertension is 2 things. One, there's a stiffness of the arteries themselves, as well as an expansion of the volume of blood. So that's what this extra salt and fluid does. So there's sort of 2 things that contribute to high blood pressure. And patients often, have some or both of these problems as contributing to both hypertension in general or the more extreme example of resistant hypertension. But if a patient has resistant hypertension, it's incumbent on the doctor to sort out what exactly is going on. And there's a variety of things that can be the case. And as cardiologists, we're often a source, a specialty source that a primary care doctor might send a patient to for difficult to control blood pressure. The 2 main specialties that handle high blood pressure are cardiologists and kidney specialists, nephrologists. But when I see a patient that's referred to me by a primary care doctor, it's often something that is a very common problem is a patient is just not taking their medicines faithfully, sometimes called non-compliance or non-adherence. And patients may have really good reasons, but they sometimes won't tell the doctor because they're afraid that the doctor's going to get angry or something else. So the doctor will prescribe the one drug. The patient will have some kind of side effect. They'll stop it. The doctor prescribes a second drug. The patient may continue to take that one. The doctor prescribes a third drug. So there's a list of multiple medicines, but the patient really isn't taking them all. So compliance or adherence is really a first order of business. Is it really the case that the patient's taking these 3 drugs or more and subsequently not having good blood pressure control? So that's one thing that I think is really important. But there are some other issues, of course. There's a thing called secondary hypertension, meaning the blood pressure is not elevated just because of the stiffening of the arteries and salt retention, but there's some other cause, like a hormonal cause. And we have easy ways to screen for these secondary causes, but they make up a very small percentage, 5% or less of total blood pressure patients. And then the last thing that sometimes is an issue, and we always want to think about it, and our patients sometimes over-ascribe blood pressure issue to this, and that's the issue of white coat hypertension. Tell me what your thoughts are. Share that with the audience.
I was about to actually make the comment that I think people rely on that a little too much, and if anything, to me, it's we might
describe what it is first, and then
sure the thought that the anxiety of going to the doctor's office is what's raising the blood pressure, and that elsewhere in the real life, in the real world, the blood pressure isn't high. And I think we as physicians can sometimes be tricked into agreeing with that as well. that because any stressful situation in life is going to be causing these elevations in blood pressure, and there's no way you can avoid that in day-to-day life. And I think most studies will show, or many studies will show, that people who have a diagnosis of quote-unquote white coat hypertension, when they wear these ambulatory blood pressure monitors, usually show episodes and times of high blood pressure, and that those who are just checking it on their own at home are often checking it at times when they're relaxed and not stressed, and it's going to be a normal reading. But that I've seen many people who have the so-called white coat hypertension, that when you put these monitors on, they have high blood pressure throughout. So I'd like to try to avoid falling into that trap, certainly.
Right. Well, I would take the Ronald Reagan approach on that, as Ronald Reagan said with the negotiation with the Soviets or the arms race, that we can trust, but we have to verify. So we can't just say, I have white coat hypertension, it's always high when I see the doctor. We need to prove that your blood pressure is lower at home when you're at rest. So I think that that's the easiest way to make that diagnosis. But you also mentioned this other method, ambulatory blood pressure monitoring. So to move along then, in terms of, how often is this whole high blood pressure, how much is this whole high blood pressure thing happening? I mentioned to you that there's a lot of Americans, the significant blood pressure elevation may be as much as 30% of Americans. So a lot of patients, a lot of people out there in our population. Hypertension awareness is, however, really not very high. So it's really one of those things. If you look at this data called the NHANES data, where they look at people who aren't living in institutions, those free living people out and about, the NHANES data says that the awareness of someone who actually has high blood pressure is only 74%. So only 3/4 of people who actually have high blood pressure are even aware that they have high blood pressure. And then the number of patients that are actually on treatment is less than that, 71%. And the number of people who are actually controlled with their high blood pressure is abysmal at 46%. We're not even treating half of the people in this country adequately with high blood pressure. So that's the basic information. Some different groups, men seem to be worse, younger people are worse. And one ethnic group that was brought out in this NHANES data is Mexican Americans are groups that seem to have higher problems with these awareness, treatment, and control issues.
So before we jump into talking about some of these newer therapies and exciting technologies, maybe you can spend just a few minutes talking about just good old-fashioned treatment. Just real quickly, what do we do?
Well, thanks for reminding me, because I did want to do that review. So blood pressure, you have high blood pressure. Of course, part of it is what the level of high blood pressure is. I mentioned earlier that a cut point is 140. I mean, I guess I'd ask you, let me throw it back to you. If you saw a patient with a blood pressure of 180, how is your management of that? Maybe let me ask you, how do you manage that?
The 180 is a little different for me than, say, the 145, for example. With the 145, we can really, depending on what other conditions they might have, could really talk about lifestyle changes, weight loss, exercise, dietary changes, reducing alcohol, a lot of different things you can do, and that's a reasonable approach. The 180, however, it's a little tougher to just say, go jog a little bit and you'll be fine when they're sitting in your office. So those are people I often do right off the bat advocate for jumping onto medicines.
Okay.
And there can be a lot of different reasons why you might pick one medicine versus another in somebody, which I'm sure can get into a little bit.
Sure, but I know you've done a beautiful job in our prior segments advocating the lifestyle changes, but I think that I want to be clear that I don't think you meant to say that you would only give the lifestyle changes to the patient who has mildly elevated blood pressure. We want to advocate it for even the high, but we couldn't expect to get the patient to 140 with lifestyle changes alone. I think, is that what you meant?
Yes,
okay.
absolutely.
So there's, of course, diet and nutrition is a big part of that, is a diet that's sometimes called the DASH diet, has been recommended. People can look that up on the internet. But it's a lower sodium diet that's thought to be healthy because it involves more fruits and vegetables and less processed foods, thinking that that's less of a sodium, less saturated fat strategy for health for high blood pressure. And of course, weight loss, a small amount of weight loss can make a big impact on blood pressure. And I know you've been a proponent on our show many times of exercise having an impact. But I think each of these has a small impact. Taken together, you might get 10 points of blood pressure lowering if you did all three of these pretty well. Even a little bit, even 3 or 4 points, it matters, but I think in the long run, you might get 10 points out of all of those if your blood pressure is high.
Yeah,
Is that fair?
Yeah, I was going to say, I've often heard the sort of offhanded remark that a good commitment to therapeutic lifestyle changes, diet, exercise, weight loss, is as good as one antihypertensive medicine. It just seems like a fair statement.
I think that's fair.
Yeah. So that's always step one, certainly.
So then let's briefly talk, and then we've covered this topic again on prior shows, but you can find those on our web. But the drugs, I think, broadly go into 4 categories. There's other, but our main 4 categories are A, B, C, D. And A is for angiotensin or angiotensin receptor blockers, ACE inhibitors sometimes called, that's A, ACE inhibitors. B is beta blockers, C is calcium channel blockers, and D is diuretics. I'm not going to review those again, but those are the 4, and we often use several. Sometimes patients are disappointed, they need to use more than one, but it's quite common that patients need 2 or 3 drugs.
Yeah, and I've read statistics saying that on average, a adult over the age of 50 to get blood pressure control averages 2.7 medications per person, so almost 3 medicines. And I think I would agree with that. Just in practice, what you see is that many people do require that.
But one other piece of data that I would say that I would add to that, what you just said, is if people do not have high blood pressure at 50, they're not necessarily out of the woods. The Framingham Heart Study, done here in Framingham, Massachusetts, showed that if you did not have high blood pressure at age 50, you would probably need blood pressure medicines at some point in your life 85% of the time. So the vast majority of people have high blood pressure that develops as they continue to age in their 50s, 60s, and 70s. But also, if you have high blood pressure at 50, the same issue is a concern because your blood pressure will probably get worse as you're already stiffened with age, so you'll need more blood pressure medicines. So resistant hypertension is where we've come to now. Those patients who, despite being on 3 drugs, remain elevated with blood pressure. That sometimes is just considered blood pressure above the 140 goal. Sometimes it's a higher goal of 160. Either one of those we could take. Blood pressure that's suboptimally controlled on 3 drugs is resistant hypertension. So what is the general approach? And I guess I'll ask you, after confirming compliance, going through that effort to say, are you really taking these medicines? Are they agreeing with you? Are you taking them reliably, missing them rarely? What other things do you seem to do with these resistant hypertension patients?
Yeah, so I think you mentioned earlier testing for some of these rare secondary causes of high blood pressure. You certainly don't do that off the bat with everybody. There's so many people with high blood pressure, it wouldn't make sense to screen for these rare entities in every single person, but I think that is when you start to consider it, when people require more than 3 drugs at full dose to get the blood pressure under control. And also, I think we've learned more about some people respond to some medicines better than other medicines, and there's ways to test to help that as well, which you may get into a little bit, to help figure out what agent might be the best one to add next.
Sure.
And so maybe, yeah. And
so I think those are great suggestions that you just made. I think those are basically similar to what I would do. The only thing I just want to mention is that one of the things that I've, through my efforts to try to stay on top of this topic, have learned there's a couple of older medicines that seem to be a little bit better, and one is this medicine called chlorthalidone. It's a medicine that is in the same family as a medicine called hydrochlorothiazide. But seems to be a little bit better at getting blood pressure down. So that's a simple solution. It's a generic alternative.
I would add anecdotally, in the past maybe year to 2, I've been either switching or using that one more, and definitely noticed anecdotally a big difference compared to the hydrochlorothiazide.
Yeah, so I think you can see sometimes 5 or 10 points more blood pressure lowering with just that one switch. Yeah. And another drug that's commonly recommended is a drug called spironolactone, which is another diuretic. That also seems to have really good effects for these patients who may have difficulty getting blood pressure controlled. But I would say what you just said, which is one of those things that even when I was young in training, I didn't understand why doctors did this whole blood pressure thing. And I think the whole specialty of medicine is coming about thinking about why we're doing that. Why would we give a patient a medicine, and if their blood pressure doesn't come down at all, would we add a second medicine? Why wouldn't you just ditch that medicine because it didn't do anything good and give them another medicine? But we just have this, what's called a stepwise approach. That's what's been written in our textbooks. That's what we were taught. You give them one. If they're not good, give them a second one, give them a third one. And I think we're starting to say, well, if this drug didn't do us any good, let's get rid of it rather than add additional medicines.
Yeah, it's tricky because if it does achieve some success,
right.
5, 10 points, is that a success or not a success? And it's a tricky thing. If it's doing absolutely nothing, I can see your point. Absolutely.
Right. So as you said earlier, there is a range of blood pressure effect with any drug, and if your blood pressure effect on one drug will be different than mine, of course. Right. So that range could be from almost nothing, 0, 2, 3 points, up to an incredible 15 or 20 point lowering for patients, with most people, of course, in the middle. On average, you said maybe 7 or 10 points of blood pressure lowering per drug on average. But of course, you may be 0 for this one and 15 for the next one, and vice versa. So that's an important concept for people to keep in mind. And it requires some patience. Some people get frustrated with me. I give them a drug and I have them come back and want to try to work a little bit harder. But it takes some patience and some commitment to try to really stay with the drug to see. Some drugs I caution patients to know, for instance, the A drugs or ACE inhibitor drugs, they're not fully active for a full month. So some people after 1 or 2 weeks say, well, it didn't do anything, and then they quit it. And it really requires our teaching of them to say, please stick with it for a month to see, let's see what the full effect is at the end of the month. So I just wanted to mention that I think what we've covered those issues about, using 1 or 2 or multiple drugs, trying to use them at an appropriate dose and making some changes. Do you have anything you want to add in that?
No, I was going to add to one more thing, I guess, with the drugs that we often also, by purpose, start off low with the dosing. For example, this drug, lisinopril, you're talking about, the ACE inhibitor, comes in lots of different doses. And I've had some people express frustration that when I give it to them, it does nothing, but I give it to them at a low dose to start, for example, of say 5 milligrams, when in fact it can go up to as 40 milligrams. So sometimes it takes some time to bump up the doses. Like anything, you don't start at the highest dose.
Right.
And so that's another source of frustration for some people sometimes.
Yes, yeah, and I understand that patients are busy and they want to keep seeing the doctor, but these are really important things that I think require, a little bit of time invested getting on the right regimen. If we find the right regimen, you're going to be on it for a long time with really minor tweaks over the year. So I think that's a good point. So again, we're focusing on hypertension generally, but risks of resistant hypertension, of course, is what you might expect. If blood pressure is a risk for strokes and heart attacks and kidney failure, the 3 big things we worry about, the risks of having blood pressure that's really high is even more strokes, heart attacks, and kidney failure. So I think that's the important thing that people want to talk about. I guess congestive heart failure would be another risk that we'd really want to focus on as a risk. So the last thing I guess I wanted to just spend a few minutes, but before I talk about this sort of new technology that's not available in the United States, but I want to talk a little bit about, is there anything that you would like to add before we delve into that?
No, I'm actually very excited to hear more about this stuff, and I think our audience will be very interested in hearing about it as well, so maybe we'll just dive into that.
So let me just briefly talk about what I'm going to talk about is this thing called renal denervation, and renal refers to the kidney, and denervation is just knocking out the nerves. So renal denervation is a technique that's actually now available and being used in clinical practice in the countries of Australia, Canada, and all of Europe. It's been going on for several years with pretty good results. And in this country, it's not currently available, but it's available in some clinical studies which are going on, and people can find out about it if they're a candidate for it by searching on the web or contacting our office if they're interested. But the concept is that there is a connection between the kidneys and the brain and the heart and release of hormones that cause our blood pressure to rise. What I like to tell patients briefly is just a general way to think about this is that the kidneys are like the thermostat for blood pressure. So if you set your thermostat at a certain temperature, 70 degrees, the thermostat gives a signal to the furnace to turn on if the temperature goes below 70. Well, that's sort of the way the kidney works. I'm being very crude and simplistic here, but just to help people understand that the kidneys make a bunch of messages. They make hormone messages and nerve messages that say raise the blood pressure. Now, people will say, well, that's stupid. Why does it do that? Well, it's very important because if we are ever shot or stabbed and our blood pressure falls, the kidney does a lot of important things to try to raise the blood pressure, to save our lives, to protect the brain and the heart, because we need a certain amount of blood pressure to stay alive. So that's a really important thing that the kidneys are doing as an important function. So the kidneys are sending these messages, but they may be sending messages inappropriately. They may be running too hot, to use the thermostat analogy. So one idea has come about and now has been proven in some European and Australian studies that by knocking out these nerves, you can actually lower blood pressure in a substantial way. So that's what I wanted to spend the rest of our time talking about, this very exciting technique that's not available in the United States except in a clinical study that people can find out about. And I'm just going to describe that. So what's involved in that is a catheter is placed in the groin, like a heart catheterization. A physician like myself that does catheterization procedures can put a needle in the artery of the groin, and through that needle in the artery of the groin can put a catheter up to the heart. And then through that catheter, put a catheter that can deliver an energy. It's called radiofrequency energy that can actually injure the nerves and knock them out. And what's been shown is very exciting is that this can be done very safely with almost no risk to patients in these trials that have been done elsewhere around the world. the risk of bleeding or bruising or any kind of injury to the kidney arteries is very, very low. And the benefits is really substantial. I'll just share with you that the first study that was done actually in Europe and Australia was a multi-center trial. And I'll just say that at the end of 1 month, patients' blood pressure was down by, the top number we'll just talk about, the systolic blood pressure was down by 19 points. And you and I talked about how one drug is about 7 to 10. So this is like 2 drugs at the end of 1 month. At the end of 3 months, it trended down a little bit more to 21 points lower. By the end of 1 year, it was down to 26 points lower. And then it settled out at 2 and 3 years at 33 points lower. So it's a pretty amazing thing and seems to have stayed there now further in further follow-up.
I have lots of questions. So I guess to follow up on that, have there been any longer-term findings of any deleterious effects from this?
No, it looks like this is really, many of the questions that were asked, that you're asking very appropriately, is what happens if the patient in these circumstances is in a car accident or does get shot or bitten by a dog? Can they raise their blood pressure? And there doesn't seem to be any ill effects in the early experience. Now, again, I'm not touting this. It's not available in the United States. I can't prescribe this to my own patients. But what we're seeing in other countries that are substantially ahead of us in experience, again, not even using this anymore in trials, but actually using it in clinical practice, is that there does not seem to be a problem with low blood pressure in the long run. The good thing I think I would say just from a very practical standpoint is that these patients are on 3 drugs. So over time, there's plenty of room to back off on drugs if you do have this 33-point blood pressure lowering. And many patients probably would be happy to obviously be on less drugs with good blood pressure control.
Sure. And maybe just from a logistical standpoint, in my own education here, maybe you can tell me a little bit more about the actual procedure and treatment. So the catheter goes up, you go into the renal artery, and then what? Do you have to find the nerve? How does this work? Do you just zap away, or what's done?
Well, it's a great question. It's an area that for those people who like to invest in things, this is an area of huge potential growth for many of these medical device companies. There are said to be 20 different device companies that are making these different devices to injure the nerves in a variety of different ways. Some are using radio frequency energy. Others are using other different techniques like injecting alcohol, a chemical that can injure the nerves with a chemical approach. So there's a variety of different approaches. But the company that is the furthest out in front of this uses this radio frequency device. And what it does is it makes contact with the wall of the artery because the nerves reside just on the outside of the artery. And it's a really wonderful design. The grand design of our bodies is that outside the kidney arteries are these sensors. And these sensors are like the thermostat. They're there on purpose because the kidney artery, when it distends or has higher blood pressure, the sensor picks it up. So we're basically turning off the sensor's ability to detect that. So to answer your specific question, yes, the kidney artery is accessed from the groin, and then the sensor is placed in a series of 4 or 6 injuries are placed around the artery in circumferential mode. And the sensor can tell the operator when you're actually making good contact with the wall of the artery. And they're done for about 20 or 30 seconds each one, and you make about 4 to 6 in each artery of the kidney, so on each side. So the procedure lasts under an hour in total time, and the patient does experience some pain, so they are given medicines for comfort. Not so much pain with the catheter type procedure, but this actual burning of these kidney nerves can cause some pain that can the patient is treated with pain medicines for.
And what have you seen? People just stay overnight one night and go home the next day?
That's the current standard in these clinical trials that are being done in the United States. I would think that in the future, like the trend is with catheterization, eventually these might be same-day procedures for patients who come in the morning, go home later in the same day. But yes, that's the current standard.
So what's the status in the U.S.? When will this be, or will this be a reality for?
Well, of course, you can never answer that question, will it be a reality, because the United States regulatory body, the Food and Drug Administration, requires a United States-based study, which is now going on. So based on whether that result shows good both efficacy and good safety, would then have to be reviewed by the FDA to see whether in the United States that would be approved. But that the first United States study is now going on. I don't know how many years that will take to complete. So we're at least a couple of years away, I would say, maybe even 3 years away before availability in the United States. So the only way people can access it for the next couple of years, if they are interested, is to find one of these clinical trial sites.
And are there any, just to always ask play devil's advocate, are there any naysayers out there or big critics out there who are saying, stay away, don't do this, with good reason, or what's
Well, I think that naysayers would say the early adoption question. Should we do anything that there might be a good alternative for? And I would say in this situation, there isn't a good alternative if someone's blood pressure is consistently over 160 despite 3 drugs. Yes, you could add a 4th or 5th drug, but those have risks as well. And the second thing I would think is that we don't know about the long-term effects. We have data out for 3 years now. Could there be issues at 4 or 5 or 6 years? So those, I think, are legitimate long-term concerns. The good thing about being behind is that we have other data from Australia and Europe that's being accumulated. So by the time we get this in 2 or 3 years, we're going to have 5, 6, or 7 years of data by these other countries.
Is there anything else coming down the pipeline that you know of, technology-wise, to look at resistant hypertension treatments?
There have been other trials of other strategies that people had some interest in. There was a device in which you could use a pacemaker to put on another receptor on the carotid artery. That was a very invasive strategy. It required implantation of a pacemaker, required a surgeon to dissect the nerve off the carotid artery. And the effect seems to be less good than this effect. The drop in blood pressure is less than this. So I think that's going to have a really harder time for adoption. I'm not sure it'll ever even come to the United States. I think that this is a potential winner based on what we're seeing in other countries.
Sure, great. Well, we're starting to run a little short on time, so I wanted to maybe just quickly close this up and maybe summarize what you've talked about, and we could talk about it a little bit. And I think you did a great job and it was very informative for me, and I know a lot about this, but talk about how common of a problem high blood pressure is, telling us a little bit more about what this entity resistant hypertension is, how we define it, who's got it, how many people have it, how we approach it, how we treat it, what we do about it, and why we do that, because there are some downsides to letting this blood pressure rage onwards, and then really going into the this new exciting technology and potentially available to everybody someday of the renal denervation. I think is a real exciting thing. The studies are very exciting and gave a nice, quick, simple overview of it all that I think made it very easy for people to understand. And so with that, I will close and thank the viewers for joining us for another edition of Matters of the Heart. It was brought to you by Pentucket Medical Cardiology and Haverhill Community Television. I was joined today by Seth Bilazarian, and my name is Dr. Sunny Srivastava. Thank you once again for joining us.